Good afternoon. I'm right before break, and that's never in a good spot to be because there's people usually ready for their break, ready to doze off. Thank you for the opportunity to be here. I always really enjoy interacting with the folks that help us do a better job, and I got into this many years ago for the same reasons that many of you, I think, got into this world of keeping patients and people safe. I began my career as an X-ray tech. And it was actually the physicist in the hospital that reached out and said, I think you might like this. And that's how I started. So what I wanted to talk a little bit about today, we have a lot of new technologies. We have a lot of new ways that we do things in radiation oncology. And it always comes back to the same question, I think, which is physicians will come to me and say, what do I do? How do I get this technology into my clinic? What are the steps that have to be done with the regulators? What are the steps that have to be done to assure that we have consistent and accurate repeat imaging? What are all the things that we have to take into consideration? And then the other thing I think of down the line is when they do get audited, or the auditors come, whether it's a state of California regulator, whether it's a Joint Commission regulator, whoever is coming, they all have more or less different questions on what they're really interested in focusing on. So I'm hoping that I can run through some of that. And if you have questions, be happy to answer those. But also, I'm always, when I do things like this, I'm always looking for feedback from you guys as to what you, as regulators, when you come into a facility, what would you like to see? Because I like to share that with my colleagues, saying, I really think we should have this when they come to talk with us. So that being said, let me get going here and make sure I can do this right. Okay, I can't. Yeah, I can. So my steps along the way are to talk about the regulatory requirements in radiation oncology, quality management, safety management programs, who really regulates that, who tells us we have to do that, who comes in and looks at, are we doing that, why is it important for administrators and physicians to spend the money to do a lot of elaborate testing and documentation. Program accreditation, I'm going to just touch on that. That's an optional thing. In many states, it's certainly not optional in areas where reimbursement is associated with it, but in some places they are not accredited, and they don't really have to be. And then incident learning methods. I'm going to talk to you just a little bit about that, because if you haven't been hearing about it, you will hear a little bit more about it, which is really being responsible for your clinic, for the delivery of dose that you've delivered, and then you find an error. How can you help your colleagues learn from your error? So a little bit about that too. So first and foremost, why do we have a need for there to be quality measurements? It's because we integrate so many systems to deliver a dose to this patient, from simulation, like Kate just said, from simulation to actually treating, to imaging while we're treating. How do we go from all of that and make sure we're consistently in the right place at the right time? So from treatment planning to delivery to reviewing what you've just done, there's a lot of technology involved. So how do we measure that? How do we look at that? And how often do we do that is really the questions that are asked. So as far as regulatory requirements, our administrators and our physician groups and my colleagues, it's not just people that are necessarily from radiological health or from the NRC, but it's also advisory people that they take into account, and they hold them in high esteem, understanding and knowing that they need to also meet other conditions that aren't typical in many areas, but radiation oncology would have specific things that are related to one of these groups. So that being said, gathering my thoughts, sitting down and thinking, how many times have I had to bring a new piece of equipment or actually bring up a department from start to finish? What do we do initially? How do we end? So there are state-specific regulations for registration purposes. The NRC are your agreement state regulations. You have to make sure that you're compliant with those, and you have to know what they are and have a relationship, which is why I'm so glad the AAPM is involved with CRCPD, because we learned as much from you, I hope, as you learn from us. The EPA, as far as in the radioactive materials world, how that is involved, even albeit minimally. Department of Transportation, all of these things that our clinics have to take into account when they put together their program. FDA and Center for Devices in Rad Health. So all of these have a little piece of radiation oncology. And state-specific regulations, where would that come into my practice? Well, the first thing you're going to do is you're going to talk to a manufacturer. They're going to say, this is the best device we have. You have to have it. Don't worry about it. Just pull out that old device and throw this in there. Everything's fine. Nobody will even have to know what happened. We all know that's not really how our regulators like things to be done. So we have to have a facility structural plan. You have physicists in your regions or your states that are approved by you to do these evaluations and confirm that if we put this device here, it's going to be structurally supported by the shielding in place, or we're going to add additional shielding to take care of this. Engineering controls, what kind of lights do you have to have? And this does vary across the country. It's not always the same. Some states are a little different than others. However, does the light have to flash above the door when the beam is on? Do we have to have a maze? What are the specifics to your state? What engineering controls can you put in place to assure your staff is protected when they're outside the room? As far as equipment registration, everyone requires there to be registration. Manufacturer sends in notification that, yep, I dropped this off. You should be expecting all your documentation within so many days. Radiation protection plan and program. This many times is forgotten, and I'm not sure if you see that when you're out there auditing. And the auditing to me, and you'll have to correct me if I'm wrong, the auditing in nuclear medicine has been around for a long time, pretty clear cut. Radiation oncology, unless you're doing sealed source implants or liquid unsealed source administrations in your rad-onc department, there's not as much involvement when our regulators come in. They have certain things that they check, but it's not a 3-day extensive audit like we have in our nuclear medicine PET programs. So it's a little different. However, there is a requirement, and I'm asked this often by my administrators, and that is, well, show me the law, Bette, that I have to do that. And if I don't have a law, which many times I don't, I'll say, the one law that they can bring in here and say you need to do this correctly and consider the implications of your staff and your physicians is your ALARA program. You've agreed with your state or your region that you're going to create a program and keep a program where your people are protected. And to me, that's what regulators look. They use that word a lot when they're doing their audits, regardless of what department they're in. So they also ask, not only do regulations, but also the accreditation bodies will also expect you to have a formal program in writing, policy-based, procedurally based. And it's not just your regulators that do that. Your accreditation bodies do that. Your guidance from recommended organizations that put things together for us, American College of Radiology, AAPM, ASTRO, whoever it is, they all say the same thing, which is you need to have these practice-based policies in place. And then qualifications of physicians and staff. Certainly qualifications is something that your physicists, your physicians have to be a particular education and training. If they're going to be using a unsealed source or sealed source device, or a sealed source device, or delivering unsealed source radiopharmaceuticals. But so that qualification it's in writing, so that's not something we can negotiate through either. So for Nuclear Regulatory Commissioner agreement states, when you get to the licensing part, certainly what you're interested in is what's the device? I mean, is it a cobalt MR device? Is it a linear accelerator? Is it a high dose rate afterload, or is it a low dose rate? What is the device and what regulations are associated with that device? So that's another consideration for the licensee to identify what they're going to be doing and how they're going to answer all the questions you will have for them. Like I said previously, training, education, where it's going to be placed. Are you going to have an HDR unit in the same room with another device, and how does that work? As far as brachytherapy or implant therapy, some people still do interstitial loads. Certainly there's prostate implants that are still occurring. Gamma knife therapy, MRI guided cobalt therapy, radiopharmaceutical treatments. I mean, there's still new treatments coming along in the world of molecular treatments, whether it's for prostate cancer, whether it's for non-Hodgkin's lymphoma. There's research facilities that are still doing high iodine, or beginning to do high iodine things, like MD Anderson. A couple others are doing them too. And it's a lot of I-131 that they're using for these patients. But so all of that being said, what is this radiation therapy department going to do? Is it going to be standard linear accelerator treatments? Is it going to be HDR? What are they going to do, and how can that clinic responsibly answer the questions they need to answer for licensure? As far as the EPA, most and all waste is tracked through your radioactive materials license, and the regulations that you have to admit. No one disposes in the sink any longer down there. I mean, unless you're a research facility, your standard clinic is not going to do these practices. So these don't really align with them. Plus, you have to agree in your license that you certainly are not going to be doing that type of waste disposal. It's decay in storage, or it's return to manufacturer, typically. So that brings us along to Department of Transportation. If you are going to be having your technologists bundle up isotopes that you're not using or shipping any type of radioactive materials, they're going to need to make sure, the facility's going to have to make sure that they have DOT training for their staff. So, and they do, certainly. And there's a couple ways to do that. And the FDA, certainly how that impacts the radiation oncology department is the FDA is who approves new radiopharmaceuticals. That process, for it being a drug, it's going to go through the steps and walks that any drug is going to go through. And also for equipment purposes too. For devices, they also have a consistent pathway that they follow that they're, required to accomplish prior to that device being approved for use. And there's always research centers that are trying out new devices or trying out new techniques on devices. So this is another group of regulators that is involved along the line of practice in rad oncology. So in quality, this to me is very beneficial to an auditor because regardless of the center you work in, there's quality procedures that have to be done to assure that you're again aligning to that same tumor volume, all the incredible technology we have available now. How can an auditor come in and say, show me that you've consistently delivered? I mean, for curiosity purposes, or just because you want to make sure that they, the stories that we hear from other centers are the problems they've run into is they've misadministered their dose to an area where it didn't belong. And how could that have been preemptively stopped prior to that patient having such a bad result to that event? So quality is what really is supposed to capture this. And when we look at quality assurance here, there's a couple of ways that you can look at it. And I think what I just described is really what we're all trying to accomplish, which the AAPM adopted. The quality is the totality of features and characteristics of radiation therapy services that bear on its ability to satisfy the stated or implied goal of effective patient care. And when you think back about 20 minutes when Kate was going through all of that discussion on imaging and how we do this to make sure we've planned it here, we deliver it here. We planned it here, we deliver it here. We talk about small doses delivered to the patient with our cone beam CT or a KV, onboard KV imagers. And when you look at that compared to the overall dose that you're going to deliver to your patient, sure, it is a valid amount of radiation to do that, but I think the alternative of completing their treatment without being assured of where you're delivering your dose, that risk versus benefit, the benefit is certainly using that KV or that cone beam CT when you're giving thousands and thousands of times more radiation overall on that patient's treatment for that total treatment. So what quality is supposed to do for all of us is have a consistency of evaluating what we do on a daily basis, weekly basis, monthly basis, annual basis. Compare that to external colleagues, partners, other centers. Compare your dose to other centers. How am I doing? Is my accuracy where it should be? And all of that is done. So I think in the world of radiation oncology, a couple of things. You typically have boarded physicists that are in your centers, typically. I'm sure there's some outlying clinics that have a consultant that comes in and they do routine treatment. Their dosimeters off-site and they send their imaging to them at this off-site and they do that. So there's a lot of off-site interaction in these tiny clinics. They're all associated with a board-certified physicist that has the responsibility for that quality program and the responsibility for that dose being delivered consistently, efficiently, and accurately. So that being said, the question is, what systematic checks do we put in place to make sure that happens? And how can I show that to you with pride when you come in the door and say, show me what you do? So what we do, the QA is required in radiation oncology by a series of accrediting bodies or joint commissioner, whatever body it is that's overseeing your area. And they all pretty much say the same thing, which is you need to have a documented quality program. Not only documented, but something that's used, something that you can show as evidence to us as being used. And it needs to take into account various aspects of that patient's treatment. So physical, clinical, and medical aspects of treatment. I mean, what does the patient look like? What is his body habitus? How is it a person that seems to be very, very ill? They're losing weight. All of these things come into play because if the patient's body size is changing, Location of that volume may be changing also. So all of that plays into why it's so important to be evaluating the patient and how accurately you're delivering something on a daily treatment basis. Organizational structure, responsibilities, who does what? Does the technologist or therapist come in the morning and verify a constancy of output? Is that done? Certainly that's done. Checks and procedures, resources. It's very important, and I know in our world as well as your world, sometimes administration doesn't understand why we need a new bell and whistle. It's very expensive. Why can't we make it with something, is there another thing we can do rather than purchase that expensive bell and whistle? You cannot have a quality program. You can't consistently promise delivery of an accurate beam delivery unless you have the tools that you need, and that includes devices. So we've been very fortunate in that. And then considerations for the regulatory requirements and guidelines and the accreditation guidelines to ensure compliance. So I'm going to show you some slides of what that content looks like, and I'm hoping to have you walk away saying, they have a lot of detail that they look at on a daily, weekly, monthly, annual basis. Those are the things, those are the reports that you should certainly ask for when you go into the clinic and say, will you run through your annual review with me and show me and share with me what that is, what that means? I do have California here. So I know when the California team, it's a very collaborative exchange when they seem to come in. I learn as much from them as they teach me. And I think that's really what I'm hoping you find in your regulatory world out there too. So also the QA committee, it's a multidisciplinary committee. And what I mean by that is your radiation oncologist is on that committee, your medical physicist is on that committee, a therapist is on that committee, you have your nurses on that committee, you have multiple viewpoints being shared at that table. So here's where I had that list. In addition, administrator, because that's your opportunity to say, we've been talking and going around and around what we need to make sure that we deliver this dose efficiently, accurately, and consistently. That's the tool we need. And to have an administrator be part of that conversation, I think, is crucial, because then they can go to bat with all the other people vying to purchase things and say, look, we really need this in radiation oncology, and this is why. And they have the education. When they walk away from those consistent QA meetings, they become very knowledgeable in their area of practice, which, I mean, many times in hospital settings, typically your administrators are nurses. I love nurses, but they don't tend to be scientists. So when you start talking down the line of science, there's many times they're like, really not sure what that means or what I need to do with that. But as they're involved in the process, they become amazingly partners in that endeavor. So what do they look at? Personnel qualifications. I mean, you're not going to have a physicist that comes in and works in your clinic and have them run your clinic and not even ask the question, are they board certified, right? I mean, you're going to vet who you have working with your patients. Physicians, the same thing. They're going to look at equipment performance. It's like, why is the output drifting as it's drifting every morning? What's going on with that? Is it setup error? Is it the technologist? Is it equipment? Is it the actual accelerator? Is it the device that I'm using? Treatment delivery process. We just started something, and I always say this so that from San Diego, 2 hospital systems, and she didn't tell you which one I'm from. If you like what I have to say, I'm from Sharp Healthcare. If you do not like what I have to say, I'm from Scripps Healthcare. So when you have a, lost my train of point, when you have a therapist, and I had said to them, we have really gone down the line of evaluating every imaging opportunity in this facility. We're tracking repeat CTs, we're tracking high-level fluoro, we're looking at skin dose, we're looking at frequencies of CTs and why did this pay, we're looking at all that in the diagnostic world. And I am the radiation safety officer. How are we doing in rad-onc? I mean, I know you're delivering a whole large amount of radiation, but we still don't need to be inefficient in how we image them. How are you guys doing? I don't know. And so I'd really like to establish a program to look at that. And used to be, a year ago, well, we only repeat image when we have to. And I said, but I'd like to have a number. I'd like to see if we can improve ourselves. Not really to do this because to tell you you're not doing your job well. How do we get better if we don't know what we're not doing? So it's interesting. They are so on board now with not only their reporting metrics, but having said, geez, I think back and I remember how we consistently had a problem with our mask holder. And it was the holder, it wasn't us. We thought it was us. but it was actually the holder. So had we not collected that data, they wouldn't have brought in the manufacturer and him say, oh, you know what we need to do? We need to do A, B, C, and D. So by collecting that data, it helped us tremendously. And them also. They've really seen their own improvement, and now they're all on board, which I think is a good thing. So we do track if you have to repeat, if additional dose was added to your patient, why? And certainly there's justifiable reasons to do that, and those are excusable and understandable, and we don't have to talk any further. But and I left them to choose what to measure. I said, I'm going to empower you to tell me how you think you're doing. And they would write everything down, and that's when they would bring it down to, I really think we can do better in these areas, and they have gotten better. So that being said, the QA program in that department helped tremendously with that. They were able to say, wow, you know, we used to really worry, Mr. Smith has had 6 masks made. Why is that when he should have had 1 and been done? So to solve those problems, if it wasn't a QA program or other people, you know, outsiders stepping in and saying, why don't we take a look at this and see why we are doing that? It helped tremendously. As far as the whole treatment delivery process, that's with your onboard imaging, or your being able to say, here's the volume, here's where I'm treating, there's a disconnect. They wouldn't have treated, they would have imaged and said something's amiss, we'll have to pull back and figure this out. And then documentation of treatment delivery. How do we document, how often does somebody look at that record? Are there consistent errors that people consistently miss until many treatments? What does that look like? And I'm going to talk about that in just a second. So the QA team gets to delegate tasks to staff members. Each member has his or her responsibilities, and they're kind of like the team lead for their group of colleagues. And what the Quality Assurance Committee does is they decide tolerance levels. What do we want to call tolerant in our practice? Certainly there's national guidelines and standards. Most guidelines or tolerances are either set at that level or below. For the medical physics tasks, we would be obligated to commission a device, do all the steps associated with that, including have it be acceptable output measurements off to the state, and then testing of the equipment prior to clinical use, or testing it according to how it's going to be used, and then maintenance of equipment. So who helps us do that? I mean, is it like every clinic you walk into, the physicist said, oh, I've done this before, we're just going to do it this way? Well, actually, there's a lot of people that help. One of the things I think the AAPM does quite well, one of many things, is we have a rich gathering of colleagues that are willing to work hard, share, create task groups, create reports, and then open it up to everybody to look at. That helps everybody down the line, not only the patients, some of the larger centers. I mean, I don't think I've ever worked in a center with more than 2 or 3 physicists. Some of our centers have like 25 physicists in them. And their love for science, technology, and advancement, those are the clinics that have volunteered along the years to put together reports that really help us. And if you look at some of these, and I know that I don't think the general public can download the reports, but they can certainly get access to what exists as far as titles of those reports. And if you look at the timing on this, these go all the way back to the 70s, I mean, a long time ago. So most importantly, published guidelines. So these are, if you're a newer physicist or newer to a technology, you've been around for a long time, but it's a new technology coming to your clinic, you can be assured that they have a resource to go to help them develop a program that's consistent with national standards. So practice guideline for commissioning X-ray image-based guided radiotherapy systems, the ones that Kate was just talking about. How do we commission those? How do we test those? How does everybody else do it? What does the manufacturer recommend? What do my colleagues, what are they doing? What's good in the community? As far as a practice guideline for implementing maintenance of safety checks, how often do you check that? Why do we check that so often? The research has been reviewed, published, and put together for you by many other colleagues. As far as commissioning and QA of a treatment planning the dose calculations, we can CT and be the best imaging CT technologists or therapists in the world. We can be the best radiation therapists on a treatment planning system. If we don't plan it right in the planning computer, it's not going to do us much good. So why do we look at our treatment planning computers? Because they have just as vital of a part. All the images that Kate showed you that had dose volume histograms, they were graphical, they could show you where different levels of radiation reach that patient. None of that would be possible unless we had simulation, 3D, a treatment planning system that can take that patient's body habitus and say, here's Mary Smith's left breast. Without that, it just wouldn't work. So we do QA on the treatment planning systems also. Another thing to ask, how do you assure that it goes from A to B to C? What are the steps along the way that you take a look at that are important to you to know that it's consistent? I think those would be great questions. As far as practice parameters, and there's technical parameters, which many physicists will be part of helping to write a technical standard, a technical parameter, to go along with the practice parameter that's been written by another organization, whether it's the American College of Radiology, the American Board of whoever, whatever board it is that's writing a document specific to a treatment. They'll bring in physicists and say, will this work in the clinic? And if so, could you help us put a technical parameter together to help people? I have many, when newer therapies come about, I tend to do a lot of radiopharmaceutical research and radiopharmaceutical research therapies. So I tend to get a lot of calls from my colleagues that are, okay, now it's hit the pipeline, it's FDA approved, it's out in the world. How do we do this? What did you find along the way could get me in trouble? Could you help me with that? Which is why we put technical standards together. So why have anybody else pay the dues you already paid, right? So we put that together so that they can have, this is where I would see a problem with you doing a Y90 therapy. This is where I would see you having a problem doing a Xofigo therapy. These are the things to look out for. These are the kind of the hot spots that you would want to, no pun intended, take a look at. So those are all in place for them also. And I didn't put these here to go through each one, just to show you the rich library of resource that we have as a group, because we're always going to get into a situation where it's a new thing for us. We don't have a colleague in our clinic that has done it, so we go to our library of resources from our other colleagues. Particularly with some of the changes in regs related to sealed source, unsealed source therapies. They've been very helpful. So I also have in the slides, these are all downloadable by the general public. That includes anybody can go to this web, so it'll be on the slides. You can go here and look at any of the technical performance standards that we would use and you would expect to see in a practice that's doing this type of therapy. You would expect to see those there and why they're there, particularly the tolerances. Safety. So we always talk about, why are we really doing all of this? Why do we have quality management programs? Why are we so interested in cone beam CT? Why? And the bottom line is, we all want to do a job where we do more good than harm. We want this person to heal, we want them to get better, we want them to go back to life, and we want them to be safe. We want to keep them safe, we want to keep our technologists safe. I mean, if I asked some of my vintage, as I am, colleagues, years ago, calibrate and linear accelerator, and you had a long maze to walk down to get in there and change where your ion chamber was. Of course we didn't prop the door at night at 1 o'clock in the morning because we had to run in and out 85 times to change. Of course we propped the door open. Now, was there an ion chamber at the end of the hallway to tell, or end of the maze to tell me, can you do that anymore? No, they've gotten around that where you just can't prop the door anymore. The older accelerators you could. So being safe, the maze was put in place for a therapist. The door was 3 feet thick, and you'd stand there waiting for it to open before you could get into that treatment vault. But the reality is, ultimately, all the programs are designed to keep not only the staff safe, me safe, you safe, everybody else safe. It's those, how do I get around this? That is always the question asked in an audit, right? So safety is no accident. This is another excellent document that was recently published by, it was actually sponsored by Astro, but it's specific to Safety is No Accident, a framework for quality radiation oncology and care. It's very much worth the read if you're auditing radiation oncology departments, because these are the groups that endorsed it and participated in this, and there's a lot of expertise in gathering these groups together. But most importantly, if you look at the chapters that exist in this document, it's not a very long document. It's the process of care in radiation oncology. So if you're really wondering, okay, they go to the clinic, then what happens? I come in here and I know what to check because I've been, my professional training has trained me that these are the things that are here, but really what's going on? When the door shuts and they're doing their work and I'm driving home, what really goes on in that clinic? The process of care in radiation oncology, I think, is a good walkthrough, explaining that specifically. The radiation oncology team, why can't I just train, the high school file clerk? I mean, I've set up the treatment. Why can't they be on? What's the big deal? It's just a superficial unit. They've seen me do it 1,000 times. Why can't they do it? Why do we need to have that in place? They walk through what you would expect to see, what people are doing for practice for a radiation oncology team. And then safety. They speak directly to all the aspects of safety to delivering a patient a good result. And keeping our team, again, I always keep in mind that I'm not just there for the patient, I'm there for the therapists that are there. I mean, how many times have I had to counsel a pregnant therapy technologist, should I be concerned, or whatever technologist in the hospital, and to be able to talk to them about what would be anticipated harmful or not for their unborn child. And in radiation oncology, the bottom line is, you've been here for 8 years, you've never gotten anything on your badge. We're still going to monitor the baby and you, but I don't anticipate this being a problem, as you're not involved in any high-risk therapy applications. But that safety goes right down to your therapists, your nurses, everybody else. I still have people that, I mean, sometimes the manufacturers have interesting concepts that they share with them about what is going on and what should be going on. Oh, you don't have to worry about that. Whenever I hear that you don't have to worry about that, it's when I usually say, well, then we should talk this through. Particularly in radiation oncology. So the other thing it goes to, again, is it's a very nice summary of management and assurance of quality in radiation oncology, why it was important to this very large group of specialists, physicians, physicists, therapists, technologists. The other piece of who keeps an eye on us kind of thing is, even if a facility doesn't have the financial resources to be accredited, and I hear that from clinics, I can't afford to be accredited, but I want to be tested in the same way. Or I have facilities that say, I want to be accredited, but administration is not comfortable releasing patient data to a national data bank. They're just not comfortable with it. You can talk around and around and around, and they're just not willing to do it. But they still want all the testing done as if they were accredited, which I commend them in. So there's different ways you can look at your program. It depends on what accreditation, first of all, in many states, many areas, is voluntary. And there are aspects of diagnostic imaging, there's certain aspects of radiation oncology that you have to be accredited, and you have to follow the accreditation. You have to choose an accreditation model and follow it, but not in all. So that being said, many places will select what they want to do and what guideline they want to follow. So reviewing the accreditation program application, program-specific review requirements, it aids the facility in deciding, is this a good match for this practice, for what we do here? And why is that important? It's another list of what you tend to see in a quality management program. But what they ask of you, and what you're going to show them or whomever is overseeing this process, they want to see your personal qualifications. I think I've said that 4 times now since I've been up here. It's really important that you have the appropriately trained people in the appropriate roles, and that can be shown to you as a regulator. I mean, how do I know? They're the person doing the HDR treatment, and my regulations say this, and are they not aligned with that? As far as staffing levels, do you have 1 physicist and 35 dosimetrists, and they've been going through physicists every year? they're wearing them out. How is the staffing level? Is it appropriate to the practice? These are all published values. Many administrators will say, yeah, but there's a fudge factor in there of about 50%. There's not, but of course, we work for different reasons. I mean, I think we are all in the world of treatment, delivery, patient getting better, and they have to find the checkbook, the money in the checking account to pay for all that. So I get their difference. But staffing levels, it's very important. It's very important to have the right people, the right number of people, and the right level of education those people, right? CQI improvement. So in other words, do you watch yourself? Do you see yourself in a trend, and do you improve that once you see that? Is that done? They expect that to be part of your normal daily practice. Practice parameters and technical standards, any of those in the diagnostic world, it's real easy to walk in and say, show me your CT protocol. Let me see your protocols for CT. And they pull it out and they show you what they do for a head, what they do for a chest, what they do for a pediatric head, what they do. Same thing in radiation oncology for practice parameters and technical standards. How do you treat that? How do you expect to simulate that? How do you immobilize them? Do you immobilize them? I've had therapists say to me before, well, we're supposed to immobilize them, but you know, she's very tender and she's very frail, and she said she's not going to come back if we immobilize her. patient needs to have a conversation with the radiation oncologist. We're not going to treat her without being immobile because we're not going to help her. It's not going to help her at all. So you get that special consideration where they don't want a mask on. You saw the mask. What did you think of that video, by the way? Yeah, and wasn't it kind of, I mean, to me, it's amazing what these patients are willing to do every day for many, many weeks, right? Or depending on whatever they've been treated. But I mean, to be immobilized like that, honestly, there's patients that can't do it. They just can't do it. And even though the mask, to our viewpoint far away, seems quite, it is confining, don't get me wrong, but you can breathe. It does have, it's an open web kind of mask, so it's not like it's a piece of plastic like, what are they, ice hockey people? Ice hockey goalies? It's not like that. It's a little better than that. So to see what they go through every day and the precision of what the therapists, and you saw that, and Kate did point that out, how they assured alignment by not only did they use their cone beam CT, they used anatomical placement or anatomical positioning of that placement to assure themselves, right? So that being said, we need to have enough technologists, and that's something that can be brought back. How can these people accomplish this? They seem a little lean, and we have had our regulators share that with our administration, and it went very positively. I mean, our medical physicist in one of our clinics was saying, I am doing the 7 a.m. to the 8 p.m. I got to get some help in here, and they just couldn't move that along. They had an audit by Radiological Health, and Brad Health said, how are you doing this? And you're the RSO for this facility. How are you doing all this? And he said, well, frankly, it's quite hard. I just have to multitask. And just by them making a comment in the exit interview, he wanted to thank him, commend him for an excellent program. And then he said, he needs help. Have you all heard that? Because I don't know how he's pulling this all off. And that was very powerful to the administrators. And my physicist colleague there has never forgotten that regulator because he now has an additional dosimetrist and physicist. Other things, so treatment appropriateness and criteria. That's held by the bodies that these physicians are trained in. You have a particular condition, you're going to treat that a particular way. Do the centers have some variation in how they treat? Yes. But do most of them go to the bigger centers? If they're a tiny little clinic, are they associated with MD Anderson or the Mayo clinics? Are they using a Mayo protocol? And the answer is yes. 9 times out of 10 they are. And that's been vetted over the years, shown, proven true. So treatment appropriateness, that's very important when you're trying to treat something and have it be forevermore. Radiation oncology or oncologist availability. Outer line clinics, the radiation oncologist may say, oh, I can only come on Mondays. I can't come when you're doing this or that or this, that. That's very crucial that you have a radiation oncologist available. Medical physicist available, particularly. They are also required to be there. Patient evaluation, treatment summary follow-up, general brachy requirements, treatment planning, policy and procedures, physics QA. Brachytherapy, I haven't talked much about that. HDR is very popular in radiation oncology. They too can walk you through what they do on a daily basis, weekly basis, monthly, annual, whatever basis, and their trending of that data on not only how is the source coming out of the source storage unit, how accurately does it go to the marker I expect it to go to. These are testing that are required and would be something that would be of comfort to a regulator to say, yep, they do it every day, and then have them, they probably won't bring the source out because they'll think it's a trick question. If you say, could you put the source out for me? Not really supposed, but you ask them to show you, how does it work? What does it look like without having the source come out of the cave? What do you do? And I think that you would have a further wealth of knowledge if you don't already from that. As far as the other brachytherapy procedures, a lot of implants, palladium implants or I-125 implants, what that looks like, what their program looks like. In the last 20 years, I've been doing this for about 26 years, it's changed a lot. Prostate seed implants, they used to take the patient's prostate and literally hold it in their hand and place needles in and put where the oncologist felt he wanted the sources placed. They don't do that anymore. It's ultrasound guided. They have, Kate showed the treatment volumes of how they could pick their fiduciaries, where exactly they're going to put their little sources or little seeds and be done with it. And then they can verify that following it as they treat later on or as they bring the patient in after they put the seeds in. How do we do? How many sources are in there? What do we expect to have in there? Great improvement with the new technology. However, what does their process look like? As an auditor, you come in and say, I see that you've added a prostate therapy implant, practice to your clinic. What does that look like? Who checks in the package? Where's the package delivered? What is your license? How do you do all that? Who goes to the OR with? Who brings the sources to the OR? All of those steps should be vetted in a protocol or vetted in a guideline for them, which is typically the medical physicist usually does all of it. Many of them receive these sources, they're already checked. They're assayed from the manufacturer, they arrive, they're good to go. You have to count them, certainly. How many did I get? They will tell you there's 186 in the vial. You won't lay out 186 and count them. You'll trust the count because you're licensed to allowed to do that, but you'll know how many you put in the patient. So that when you do your decay and storage, you can have accurate data there for when the regulators come in and say, show me your receipt to disposal of these seeds. And that should be a policy in place for them. Do you talk to the recovery room nurses? Are they bothered by the fact that this patient has radioactivity in a prostate? Because of how we now load those prostates, pardon me, we don't have as much. Years ago, they would easily leave the prostate as the patient urinated. And there were times when we would DC the Foley and I'd find 8, 10, 15 sources as I DC'd that Foley. It's not like that anymore. Honestly, we haven't had one in years that's happened. Same as we don't have patients stay in the hospital. Years ago, they used to stay in the hospital with I-131 assigned rooms. We'd have prostate implant or brachytherapy implant assigned rooms, same rooms, and the nurses would be trained in both of those for their own protection purposes. That's another important part of your quality program. How do you train people that don't normally work with radioactivity? What does it look like? What are your nurses? What do they get to see every year? Who do they talk to? What if they have an issue? What if the patient up and leaves and they come back during their rounds and there's no patient there? It'd be kind of a lost source from containment, right? So what do you do with that? What does your program look like for that? So those are all things that they vetted in policy and procedure, or should be vetted in policy and procedure. So for the other requirements, for prostate seed, most of those are implanted in the hospital, go home that day, and you never see them again. We haven't had one bounce back in 9 years, again, that they won't bounce back. So that being said, the other thing, treatment planning, policies and procedures, and physics QA. QA is very different, as you can well imagine, from an HDR unit to a linear accelerator to a brain lab to a gamma knife to general brachytherapy. It's all different. But their program should have a checklist. Typically has shouldn't have one, but typically has a one-page checklist of what's accomplished in that procedure or that modality of delivery, and that'd be a helpful thing for you to look at. Accreditation programs, they can differ. I think I went backwards. Yeah. Let's see, accreditation, so I wanted to give you an example. This was taken out of one of the accreditation programs. I'm not here going to sell any of them because that's up to the site. But they very specifically, and of course it's all about me, right? I'm thinking about physics. What they require as far as documentation of testing, what they expect you to have done. What do they expect you to be compliant with? If you remember that long list of documents I've shown you, there's QA documents, 2 QA documents in radiation oncology that should be floating around. You should be able to get a copy. If you can't get a copy of it, your medical physicist can help you with that. And it tells you exactly what's tested daily, what's tested weekly, who does it, what's the tolerance for it. It depends on the treatment. Is an IMRT treatment? Is it not an IMRT treatment? What's the percent tolerance? All of those things. And as regulators, correct me if I'm wrong, but isn't it, if they have no clue what you're talking about, you dig deeper? But when they have an answer, you feel a little better, right? That's how it's been for me. They're clueless. It's like, we got to dig deeper. And then documentation of treatment planning system, quality assurance. I talked about that earlier. We can have the best intentions, and if we don't have a treatment planning system that's been evaluated correctly, it's all for naught. Independent verification of output of each beam. How do we do that annually? How do we do that monthly? What does your physicist do? They have a checklist. In our facilities, the radiation oncology department has a report that they bring to the Radiation Safety Committee quarterly. They talk about their testing. They talk about any variances in their treatments. They bring a radiation safety report to the Radiation Safety Committee, as do the diagnostic radiology areas, the high-level floor. Everybody brings a report to that committee to talk about, and that's a great report to see because you can see what they're going down and checking and what they're looking at. So that would be another nice thing, I think, to be able to look at in an audit. Am I going the right way? Because I lost track. Okay, so when we do documentation review, you would want to say, and this is one thing I think is very important, as a, as a physicist, as a therapist, when somebody comes in and asks you a question, like, I don't think I've been doing that right, so we're not going to let this person questioning me go down that path. We're going to kind of divert, right? One of the things that we've been asked, I've seen asked in audits before is, why did your technologist do a output check on this I-131 patient using a pancake? Have they not been trained what a probing instrumentation is? And it's like, well, yeah, they have been trained, and they're actually trained annually. If a pancake probe reads in MR per hour, their line of thinking was, I'm reading MR per hour, not capability of the device, right? So that being said, when we do instrument calibrations, we changed our practice. That was probably 11 years ago that occurred. That was my center. We changed our practice so that now they're in the habit of not only what's the serial number instrument I used, when was the last calibration date, but most importantly, what was the efficiency of that device? Do I do that because I want them to have practice handwriting? No. They do probably 8 patients a month that they need to document this with, because it reminds them, had they looked at the efficiency of one probe versus the ion chamber, it would have been very clear to them, very intuitive to them, that this device isn't really what I should be looking at for this particular procedure. So procedure, what does it look like in their center? What do their procedures look like? Their guidelines or go-bys. Procedures to verify that manufacturer specifications and establish a performance baseline from there, especially for radiation oncology equipment, for testing of that equipment. I think of in the CT world also on how they differ, and certainly with our manufacturers, they differ a little bit. Quality management program for radiation therapy equipment, simulators, treatment planning, just like I said before. Also, their second check monitor unit calculations. There's a lot of checks and balances in place before they beam on. In addition to most of their evaluations prior to beaming on, each week charts are pulled. You've heard the word chart checks before. What really happens in your chart check procedure? What do you really look at? What do they look at? I mean, that'd be a very good question to ask. And who else is taking a look at these? Is it a nurse that does your chart checks? Is it a therapist? It's a physicist that does the chart checks, or a physicist team member, I should say. And how do the monitor unit calculations, how do we do when we second check this calculation? Where do we sit? And that's vetted every week that we do those verifications. And also, let's see, procedure physics chart check protocol for reviewing treatment delivery. So in other words, they will have a protocol in place for how they do chart checks, what they're expected to check off. So there's checklist galore in these departments. They'll also review checking the integrity on mechanical, electrical patient care devices. I think of this along the lines of, and this is what the accreditation programs want to know you have a policy for. I think of HDR units. I think of a source coming out or not coming out, or a source coming out and not going back in. I think of all of the integrity of these devices, and are they doing testing that the manufacturer said, you need to make sure you're looking at this and testing it with this frequency? Are they doing that? For the radiation protection program as it pertains to radiation oncology, how do they train their staff every year? How do they do that? Do they do that? And what is in that? And I gave you all of these lists because these are things that you should expect to see when you talk with them, and they should be able to provide for you. Calculations related to patient dosimetry and or physics measurements when such needs arise per clinician's request. Okay, so they meant to do the right breast, but they did the left breast. Oops, because we had 4 Mary Hernandezes in the department, and Mary got up. It was Mary Hernandez. It was an error, right? Because they didn't have the correct number of checks to assure it was the right Mary Hernandez. I'm making this up as I go, but my point is, you have this happen. Somebody has to calculate what was delivered to the other breast, and is that a reportable event? If it was completely the wrong side, completely wrong area, yeah, you're probably gonna be talking to somebody. And then incident learning. How do we learn from our mistakes? I mean, and I call them mistakes, but not, I mean, I've been involved in nuke med, diagnostic, and rad onc my entire career. And I've always said the people that are the most comfortable making mistakes and putting their hand up, who do you think is the most comfortable making mistakes and putting their hand up? Radiology, nuke med, or radiation oncology? What do you think? Who do you think would be the staff that is most comfortable saying, oh, I did this? Nuke med. For me. Nuke med is so used to doing this that, I mean, they fall on their sword like, and they don't make big mistakes, like really tiny mistakes, but they know that I'm going to help them, right? It's really, for me, I mean, no, my x-ray techs every once in a while, but usually anyways, another story. That's for a story later on, like around 6 o'clock in a beer, right? But for incident learning, the whole point is that you track things that are routinely done that could easily be corrected, or there's a huge process involved. Does it sound simple from the first day that patient walks in the door till when they're laying on the table? Because it's anything but simple. There's so many people involved, so many systems involved, and so many complex systems involved, that when you put together the steps and say, where did we fail, it can be overwhelming, right? So that being said, task group, an AAPM task group, a couple years ago now, put together a design for how do we look at failures and what methods should we try to use to look at this. They use the airline industry, aircraft industry, whatever, to be their model, because whenever a plane goes down, you know, all the people involved, what had happened, they look at every piece of what could have happened in that process. That's exactly the model and people that were spoken with. So with this tool, it's a process tree developed to understand relationships between steps. So the steps involved and in the process or the procedure. And they use a failure mode and effects analysis, so FMEA, to focus on the process. And so that's important, I think. It's not focused on the outcome, which they focus on also. They focus more on the process of how they got there. And at each step to consider how that error occurred. And you can well imagine when they do this, it's not just one person doing this, right? Again, like the QA team, they have a team of people that they talk with. How errors could happen and what effect the error could have on the clinical outcome. Most importantly, is the patient going to be harmed from this decision? And that's what's most important to them in that. So know that the AAPM is beginning this. They have opportunity for many groups to jump on board and be part of this, kind of like you send your data to them for an analysis, and you have colleagues to talk to, and you know, what we want to do is get to a point where we have a library of events where you can read through them and say, you know, that could happen here, and to learn from that. That's the whole point, I think, of this colleague-based stuff. Royals, it's a medical specialty, society-sponsored radiation oncology incident learning system. And this is what we really like to know that people are involved with when you work in the radiation protection end of your field. You want to know that their goal is to facilitate safer and higher quality care in radiation oncology by providing a mechanism for shared learning in a secure and non-punitive environment. It says it all there. Yes, you're sharing your data, but this is a non-punitive environment. We want to learn from what you learned, so incident learning, right? It's free. And it goes to a confidential, private safety organization. And, whoops, I guess I'll finish that. And I thought I had one more slide there. What they are able to do is not only go through their process of what occurred, but you can see what's the most common error in radiation oncology. And wouldn't that be something nice to talk about? Because everybody thinks, oh, not in my center. My center's not, not doing that. And you're like, well, yeah, you know how many times we have gone out there and called Mary Smith, and she came in the room and we're like, are you Mary Smith, blah, 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 and they're like, oh, no. We all have errors that could have almost been a problem. And that's what these types of gathering of this data, those are the things that we learn from that help us. So what my walk away, hopefully with all of you today, is that when you go into radiation oncology, a couple of things. Yes, there should be lists of tests that are done on a frequent basis, weekly, monthly, quarterly, and they may differ annually. What do they look like, and how did the center do? Did they go ahead and compare their beam output with other centers' beam output? That's very common. They want to know how they're doing. My physicist came in with their big water phantom, tested every depth, put an ion chamber where I needed to have measurements to take all of that data and put into the treatment planning computer. And I don't know that we talk much about that particular aspect, so I'll just throw that out in closing. How does the treatment planning computer work? Why would it know how to treat this patient, right? A CT, and I know from the CT they're going to go to the linear accelerator, but what's in between that? Well, your physicist has spent about 3 weeks to a month collecting data from that brand new accelerator, taken all of that data of when I choose this variable here, and I beam on this patient at this depth, which is where the tumor is, what do I get for output? And they capture all that data, and they take all that data, and they put it in their treatment planning system. So that when they say, okay, here's Mary Smith, we're going to treat her head, here's what Mary looks like, and her tumor is at 5 cms in depth, how much should I use? Well, all of the data in the treatment planning system is specific to their accelerator, right? Not John whatever down the hallway, but that accelerator. So that treatment planning system is very specific to the device that you're choosing to treat on. I don't know if we talked about that. That's a question I've had before. It's like, who built this treatment planning system? It seems like it can do everything. And it dawned on me, well, actually, the physicists, we put the data in there. That's how we get it to be specific to our treatment. So there's errors that occur. There's errors that occur that are extremely tragic, and I'm sure you've read about all of them. There's errors that occur again and again and again, and they go missed for a very long time. And we don't think that they've caused any problem. We don't know, because there's no one measuring that. So that's the whole point, quality assurance, whole point of looking at your team that you have practicing in that clinic. How are they trained? And how important is it to the administrators of who they're using? And then how does that team, take the baton and run with it? And then when they do make a mistake, and we all do and we all will, are they comfortable reporting that and learning from their colleagues? This is what we could have done and we will do going forward, and I'm going to share that with my colleagues. So it's a great thing to be part of, and that's all I have. Thank you. I don't know if there's any specific questions to any of the things that I touched upon, whether it's accreditation, calibration, efficient, and whatever it is. Either if you don't want to jump to a mic now, if you want to catch me in the hallway, you're welcome to. I'm sure my colleagues feel the same way. Lynn, are we going to have a panel at the end of Kate's? Oh, yeah. Or you can wait until after break and after Mary entertains you with some fancy stuff. So thank you. Are there any questions? I don't mean to push off. I know, it's break time. You're free.